The basic question that's prompted a lot of this research is, has children's mental health got worse over time? And so to some degree in much of the research we're holding age constant. We're going to compare similar age children across different cohorts. And when I refer to cohort, I'm using a term in a way where I'm neutral about whether it's a period or a cohort effect. So just to say that at the outset. So I'm going to start, in terms of this talk, I'm going to start by saying why I think it's important to look at trends in children's mental health. I'm going to briefly mention what we know about trends in clinical diagnosis and treatment of children's mental health problems, and then highlight why I think it's important to look at epidemiological data, using cross-cohort comparisons, using symptom screens to inform our answer to that question. And in particular, the methods that we've attempted to use is to compare like with like when we're comparing different cohorts of children across time, and to think about how feasible that is and how successful we've been. I'm going to briefly mention some results from our program of research on adolescent mental health over the sort of longer period of time, 1970s through to today, some replication and validation evidence, and then finally I'm going to finish with some latest findings on more recent trends in younger children's mental health. So, just in terms of clinical terms, the scale of the problem is that we know from recent good quality epidemiological surveys that 1 in 10 children and adolescents has a clinically significant psychiatric disorder out there in the population, and that those disorders have a major impact on children's well-being as well as their family life, the way they interact with friends and their learning. Suicide, for example, is the third leading cause of death amongst adolescents and young adults, and child and adolescent mental health problems aren't transient phenomena. Children don't grow out of them typically, so the majority of child and adolescent psychiatric disorders persist to adulthood. And follow-back studies using prospective sort of longitudinal data show that the majority of adult mental disorders have onsets in childhood, adolescence. The impact of child and adolescent psychiatric problems aren't restricted to the child and adolescent years. So children and adolescents with psychiatric problems later show problems in parenting, problems in employment, social exclusion, chronic illness, and early mortality. And at the societal level, there's a significant economic burden associated with child mental health problems. So there's sort of a fair degree of consensus, at least amongst researchers, that the prevention of child mental health problems is a major priority. And so that sort of, I think, leads us into thinking, well, has children's mental health got better? Are we as a sort of society, as a research community, how well are we doing? Our aim should be to make children's lives better, if you like, and reduce the burden of child mental health problems. Data from, if you look at clinical diagnoses, treatment of child psychiatric problems, the answer seems to be that we're not doing very well at all. So rates of autism, ADHD, depression, anxiety in clinical practice have skyrocketed, so very steeply over relatively brief periods of time. So there have been, for example, substantial increases in psychotropic medication, with 3 to 5-fold increases in rates of stimulant medication, antidepressant medication over the past 2 decades. And those sort of trends are evident in many countries across the world. Now, does this really tell us anything about the population prevalence of child mental health problems? And I think very quick thinking about this tells us probably no. So perhaps the increased recognition of the importance of child mental health has resulted in greater public awareness, better clinical recognition. We know that diagnostic criteria have changed across time. So, for example, classical autism is now broadened in its definition to include autism spectrum disorders. Treatment availability has changed, perceived efficacy, treatment guidelines have changed, so that might influence how likely it is for doctors, psychiatrists to prescribe medication. And more recently, there have been concerns published in the BMJ and other medical journals about the medicalization of normal behaviors. So are we changing in terms of what we define as a mental health problem compared to in the past? At the same time, it's really important to highlight that epidemiological studies show that the majority of children and adolescents with a clear-cut psychiatric disorder don't actually access services. So in a high-risk study that we've undertaken in Cardiff, adolescents at high risk of mental disorders, those with a mental disorder and significant suicidality, of that group, a third weren't receiving any, weren't accessing any services. And by services, I mean not just CAMS, also primary care and even school-based counsellors. So there's a big gap between what's out there in the population and the service sort of end. So going back to the original question, has children's mental health changed across time? It's clear that we need to look at epidemiological evidence. And in principle, epidemiological studies of child mental health have been undertaken for decades now. One of the earliest studies, the Isle of Wight study, 1960s, and others like that across the world. So there are numbers of epidemiological data points that people have attempted to pool and put together in meta-analyses. Two major meta-analyses of depression and ADHD suggest that there's been no evidence of an increase in juvenile depression or ADHD across time. So you might think, well, that evidence should be fairly conclusive. One of the issues and one of the problems with those meta-analyses is the great variability in methods across each of the individual studies included in those meta-analyses. Variations in the samples, the age of the samples, what countries they're from, and so forth. Variation in measures, variation in diagnostic systems, and so forth. And although the meta-analyses have been very careful in looking at those methodological factors and including them in their analytic models, my guess is that when you've got such great variation in estimates of prevalence, so for example in the depression meta-analyses, rates of depression in the individual studies range from less than 1% to over 25%. So I don't think any statistical controls for those methodological factors is really going to allow you to detect trends when you've got that level of noise in there. So in our own research, we sort of decided that a different approach is to step away from psychiatric diagnosis and look at symptoms. And in the UK, and especially in the UK, I think one of the sort of primary sort of scientific resources that we have are representative national cohorts. So the birth cohorts, beginning with the 58 cohort and perhaps the most recent, the Millennium Cohort study. And so we've got that sort of nationally representative data, and one of the advantages is that many have included directly equivalent or closely equivalent symptom screens in each of those cohorts. And so our attempt has been to put those together. Now, so this is where we're getting to the point where we're doing direct, hopefully like-for-like comparisons. And so before we look at the results, the sort of key question is, how like-for-like are they? What are the threats to comparability when we're putting those cohorts together? The first one is that we know that not everyone who's asked to take part in a study will agree to take part, especially in longitudinal studies. People drop out. And not only and that attrition isn't random, so there's selective attrition. The children and the families with the highest degree of problems are the most likely to drop out. A next problem, level of problem on top of this is that that level of selective attrition might change across time. So studies today have found it more difficult to retain participants in studies compared to studies sort of earlier on, say 30, 40 years ago. And so that's a first obvious confounder to consider, is has selective attrition changed across time? A second problem is that the cohorts are great, but one of the sort of idiosyncrasies of them is that at the time people have decided, actually, we've got these instruments, but we don't really think that this wording is quite right. We're going to change it a little bit. And what we found is where we've asked samples of parents to complete basically the same, apparently the same scale, where the wording has been changed ever so slightly, what you find is it can make a huge difference to estimated rates. So this is the errata scale item on where parents were asked, is your child disobedient? And one response format is does not apply, applies somewhat, certainly applies. The other response format is never, sometimes, frequently. So we've changed from a truth scale to a frequency scale. And you can see that the middle the middle response on that 3-point scale, there's a vast difference in the prevalence of, some disobedience in children. So our attempt to deal with this is to undertake calibration, where we've recruited parents, a new sample of parents where they've completed both versions of closely equivalent but non-identical questionnaires, and used that analytically in the model. And that calibration methodology involves, I'm not going to talk through it in detail, but through multiple imputation, you can line one measure up against another, as well as estimate the uncertainty around how well you're doing that alignment. And that uncertainty is reflected in the confidence intervals around our prevalence estimates. And then the final point, I'm going to come back to that in a minute, that's about change in reporting and informants sort of how they interpret questions in different studies. So I just wanted to present some data. This is relatively old data now. So when we first started on this, we decided to put together 3 large nationally representative surveys assessed in 1974, 1986, and 1999. And we focused on adolescent mental health, and we used data reported by parents using either the Rutter scale or the strength and difficulties questionnaire. And if you don't know those instruments, they're general mental health screens covering emotional problems, behavioural problems, and so forth. And the SDQ is a sort of the successor of the Rutter scale, so they're actually very close in terms of how they're worded and the types of symptoms they cover. But we did need to use calibration data a calibration methodology to align the responses across the 2 scales. We use study-specific weights using prior predictors of non-response in each of the 3 cohorts, well, especially the first 2 cohorts, and weights that were available from BCAMs in the 3rd cohort, to do our best to make each study as representative of the original cohort who were part of the study. And what we found, so very briefly in terms of results, is that when we looked at adolescent emotional problems, parent-reported adolescent emotional problems, as expected, we found a gender difference. Parents rated girls as having higher levels of emotional problems than boys, as well as a substantial change in rates of reported problems between 1986 and 99. And in terms of effect size, that's a remarkable effect size, if true, because that shift over a 13-year period is equivalent in size to the gender difference for anxiety, stroke, depression. For conduct problems, adolescent conduct problems, we found an even greater increase across time. So between 1974 and 99, so 25-year period, we found a doubling in parent-reported adolescent conduct problems. Parents didn't rate everything as having got worse, so hyperactivity, so perhaps the thing that's most topical, most in the news, is, and we found no change in parent-reported hyperactivity. So there's a number of limitations. So that was our first sort of attempt at looking at this question. Firstly, we've only got parent reports when we're interested in adolescent depression, anxiety. Really, you want to ask young people themselves how they're feeling. You have to worry, I think, still about the possible imperfection of the calibration methodology of lining up the 2 different scales. The Rutter and SDQ are general symptom screens, so they're relatively crude measures of each of those constructs, including only 3 or 4 or 5 items. And another issue, I think, is, are the population shifts we've observed, are they really relevant to psychiatric disorder? Is it just that parents are reporting a sort of shift at the milder end of the spectrum, perhaps more adolescents, having 2 or 3 or 4 symptoms rather than the hard end, where you might think this is psychiatric disorder? And again, I'm going to come back to this issue that's still not resolved here, is the issue of possible changes in reporting. So we decided that we need some replication evidence and some validation evidence. So the replication study is a study of teenagers assessed in 1986 and 2006. And here we decided, rather than going for what's out there in terms of publicly available data, we decided we want to do a direct replication of in terms of measurement, of what was already there at an earlier time point. And I'm not going to talk about this today, but it's hard enough lining up measures of mental health, but it's especially hard lining up measures of explanatory factors. So that was part of the reason why we decided to do a direct replication. So in this study, we had 2 samples of 16-year-olds, 17-year-olds with identical self-rated symptom screens. And what we found is that for girls, we found, again, an increase in self-reported emotional problems, perhaps a bit less so for boys. And in terms of severity, what you can see here are odds ratios comparing the second versus the first cohort. And the difference, the discrepancy between the two cohorts became more marked the more severe our threshold on what we deemed to be an emotional problem. Again, no general shift in reporting, so no change in reports of hyperactivity. So, do these trends really reflect a shift in prevalence, assuming that we believe the equivalence of the samples and the equivalence of the measures? Well, it could still be that informants have changed in how they interpret questions, their thresholds for rating whether a problem applies or not. So one possibility is that parents and young people today have different expectations, different internal thresholds of what is problematic and what is normal, and that might show through even when answering exactly the same question. Another problem is that perhaps respondents are more willing to report problematic behaviour today in more recent generations compared to the past. Well, the specificity of the findings, so no increase in hyperactivity, might make us think, well, there's probably not such a simple explanation, but really validation using external criteria would be desirable. So I'm going to skip to this slide. So what we did is we decided that the logic here was that if informants, parents in an earlier cohort have a different threshold for rating conduct problems in their teenagers compared to the later one, the later cohort would include more cases with mild conduct problems than the earlier cohort. And what you would imagine then is that the implications of having conduct problems, which on average is a milder set of problems, would be less marked when you look later on in terms of later life outcomes. And when we compared later life outcomes, we found that multiple adverse outcomes, this includes homelessness, dependence on benefits, ill health, parenting problems, and so forth. We found that the sort of consequences of having conduct problems in adolescence were identical across the two studies. So that sort of gave us a bit more, we felt a bit safer in assuming that perhaps it's not simply an informant shift across the studies. Now, of course, that kind of method relies on having later longitudinal outcomes, which we haven't yet got for some of the most recent cohorts. Okay, so I'm going to finish off very briefly with some of our latest findings on trends in younger children's mental health between 1999 and 2008. Again, 3 nationally representative samples, this time using identical screening questionnaires. And what we found is, interestingly, that problem levels declined. So we found some evidence for improvement, especially amongst younger boys' mental health between 1999 and 2008. And we found that those conclusions held regardless of whether we looked at parent reports or teacher reports. And we also found a decline in problems when we looked at the sort of more at the extremes on the SDQ and looked at a number of children scoring in the abnormal range. Interestingly, we found at the same time an increase in rated impact of problems. So parents and teachers were also asked about how, what effect do these problems have on this child's behaviour. And we found that when we had equivalent levels of problems in the 3 cohorts, the rated impact on classroom learning had increased over that time period. So to conclude, I think it's really essential when we're interested in child mental health trends, or mental health trends generally, is to think very carefully about the assumptions one's making when we're saying we're comparing like with like. Replication and validation is important, and from this study, our research, and a variety of other studies across the world in the UK and other studies, we're fairly confident that there have been long-term changes in adolescent mental health, but not affecting all aspects of mental health. So particularly adolescent emotional problems, anxiety and depression, and conduct problems seem to have changed across time. But those trends may not be a sort of steadily getting worse. It seems likely that there are changes with sort of periods of decline in mental health in young people and periods of improvement. The latest data we've been able to look at so far from the Millennium Cohort Study is 2008, and it's really quite important to think about what has happened since that time, given the effects of the economic recession. So I'd like to just acknowledge some of the collaborators on this program of research, as well as people who helped us with the 2006 survey and the funders. And again, on the website, there'll be a list of some of the papers I've cited in the presentation. Thank you.